So I'm sorry for this delay. And my topic today is the adductor canal block. And this topic is probably one of, if not the most difficult, one of the strangest I had to deal this last year. Because it was, at least in my mind, extremely difficult to understand why an adductor canal block would be as efficient as a femoral block, knowing that typically with an adductor canal block, you are only going to put asleep about 1/5, 1/4 of all the femoral branches. However, we have to admit when we look into the literature that each time that there is a publication on this topic, the adductor canal block, the patient having an adductor canal block, have exactly the same pain relief than those having here femoral nerve block. So obviously there is something very strange. And we have noted the adductor canal block has been described for 4 or 5 years. We have already several meta-analyses showing that while looking to the quality analgesia as attested by the VAS pain score, the opioid consumptions, the results are exactly the same. And even more, while looking to the force, the strength of the lower limb, patients having an adductor canal block perform better than those having received a femoral nerve block. Nevertheless, I'm somewhat puzzled while looking to the global direction that we are taking actually, because a few years ago we were performing supranural block, so it means that we were extremely fine, extremely tuned. We were looking extremely well to the nerve. Now we have moved to the plain block. It means that we are puncturing exactly between the two nerves, and now we are doing something like flood block. It means that we are looking to a target, and in fact, as I will show you, most of the effect of the block is somewhere else. This is a completely truncated view that will help us to deal with our problem. During many years, we have all learned, and we are doing it nearly every day, we have learned to do femoral block exactly just above or just at the level of the femoral artery bifurcation. We have learned to do our popliteal block exactly at the level of the nerve bifurcation. And suddenly, now we are being told to do adductor canal block somewhere along all the femoral artery. And this picture is quite interesting because on the same pictures we see that we have the femoral nerve block, but the pictures is centered on the artery so that we see clearly that at the start this femoral artery is very close to the femoral nerve, of course, then moving downside closer to the obturator and to the sciatic nerve. So it is obvious that there are major differences between anatomical and anesthetic definition of the adductor canal, and we will see it immediately, that the structure surrounding the femoral artery depends a lot on the level, and of course, and that's evident, mechanism of action will depend on the level. Original publications, while all anesthetists were performing day block at the middle of the thigh, Swedish people were obviously working higher because the middle of the thigh is starting for them at the middle of the iliac crest, while others work also at the middle, but they are starting here at the level of the Cs. Practically, we are in 2 different anatomical regions. Some are in fact working at the level of the femoral triangle, while others are working at the level of the adductor canal. And by the way, it's interesting to notice that all these guys, and mainly Swedish people at least, are working at the femoral triangle for probably very simple reasons, is that they are doing day block often after surgery at the end of the day or the day after, before or after the rehabilitation. And there is a surgical drape that forces them to work somewhat higher. So the femoral triangle was originally described by Scarpa and is bordered on one side by the sartorius, on the other side by the adductor longus. And it contains all the femoral branches, while on the other side, just below the femoral triangle, you have what is called the intercanal or the true adductor canal. And this one is in fact covered by a very strong aponeurosis that goes from the vastus medialis muscle to the adductor magnus. And extremely importantly, this adductor canal contains only 3 structures, and that's important: a femoral artery, a femoral vein, and just one very small saphenous nerve. We will, in a few seconds, see why this is important. So, what about the femoral triangle? When the femoral block is performed at the level of the femoral triangle, the saphenous nerve and the vastus medius nerve are still together. And both of these nerves are responsible for the innervation. So we have here the vastus medialis, we have here the saphenous nerve. And these 2 nerves are responsible for the innervation of the medial side of the knee. And this is extremely important, as our surgeons are actually opening the knees on the medial side. And it is important as the most painful pain generator is in fact due to the capsule opening. But very shortly after the initial descriptions of this femoral triangle block, several cases have been published with patients having a complete motor blockade of the quadricipital motor blockade. This occurs after single shot, this occurred after continuous block. And there is a very simple explanation that has been provided here. You see that while increasing the volume from 2 to 5 ml, you have a dye spread going cephalate very close to the nerve root, to the femoral nerve root. So very clearly, when you do a triangle block, of course, you are looking firstly to the saphenous nerve, you are looking firstly to the vastus medialis nerve, but you have most probably at least a subclinical effect all along the different branches of the femoral nerve. I've already quoted several times the importance of the vastus medialis nerve here. This nerve is, of course, responsible for the innervation of one part of the quadricipital muscle, is delivering most of the time 3 main branches, and the most important for us is the third one, that is branches going to the femoral shaft, to all the articular structures and periosteal surface. So we were a few seconds ago here at the level of the femoral triangle, and we are entering here at the level of the, I'm sorry, I have missed one slide. And while looking to this vastus medialis nerve, this nerve has its own pathway. It doesn't follow at all the saphenous nerve. It is in its own way away from the saphenous nerve. This has been described here in this paper and has been confirmed by Thomas Benson here in several papers. Now, should you work slightly downside at the level of the adductor canal block, you are in fact working just here below the vastomedialis membrane in the canal of Hunter. And we see that in this canal, you have just and only the saphenous nerve. And this nerve is not the most important, as it is going to give just the retropatellar branch here. It means that if this approach works, you have to find another mechanism of action. And this mechanism of action is probably due to the presence here of the obturator and the presence here of the sciatic nerve. So in fact, while performing the block slightly distally at this level, you will use this membrane as a launching pad. And that's important. And first of all, we are going to see if this obturator nerve and here this sciatic nerve are important for the innervation of the knee. This has been shown in several papers, and most recently by F.R.S. who is working together with Vincent Chan in Toronto. And you see the patient having received a sham block, it means an injection of saline, were not pain-free at all. While those having received a sciatic block, wherever the sciatic block was performed at the popliteal level or subgluteal level, this patient had quite good VAS score around 3-4. Exactly the same paper has been published with, in order to look on the influence of the obturator nerve. So these two nerves are extremely important. Just one word looking on the vasoadductor membrane. This membrane is an extremely strong one, as I showed it already, that is located just between the adductor magnus and the vastus medialis muscle. And you see that you can even put a scissor in between and lift the leg of the patient. It's a long one, as it measures about 7 to 8 centimeters, and it ended about 10 centimeters above the patella. The obturator nerve, you all know him. And when performing a block at the level of the true adductor canal block, just above the inferior hiatus, somewhere here, you are between the vastus medialis here, muscle, you are between the adductor here, muscle, the great adductor muscle, close to the femoral artery, just behind the membrane. And we have done several studies on this topic. And while doing clinical studies, we had first a very strange and exemplative cases. This patient had a normal adductor block, and after surgery complained of a complete foot drop, a complete paralysis, as well as inflection, as well in extension. Fortunately, this patient had a catheter. We sent him to the Department of Radiology in order to perform a CT scan, and that's what we discover. You have the femoral shaft here, you have the vastus medialis muscle there, the adductor magnus there, the sartorius, the gracilis. You have the femoral artery and vein, still femoral, and you see that the dye is perfectly located in all this area. But a few slides below, 10 centimeters below, that's what we are discovering. We have still the vastus medialis, the adductor magnus, the sartorius. The popliteal vessels are here, and we see that the dye is going from one side to the other side, from the sartorius all around the femoral vessel, very close to the bicipital muscle here, and the sciatic nerve. What does it mean? This is another patient. Dye is going from one side to the other side, from the sartorius area, popliteal vessels, very close to sciatic nerve. This is important because in this area, we have possibly the vastus medialis nerve in its own shaft. We have the saphenous nerve. We have around the femoral vessels, we have all the popliteal plexus, and this is extremely important because this popliteal plexus is responsible for innervation of all the posterior capsula. And we have some dye around the sciatic. We are not very interested in the sciatic, as I will show you, but we are interested to the branches, the genicular branches of the sciatic nerve. In the clinical study we conducted, we showed that after performing a block with 20 ml of ropivacaine 0.75 at this level, we had no motor impairment in the flexion or extension of the feet. And as I said to you, I'm not very interested in blocking my sciatic nerve. But we have still an involvement of the sciatic showing very clearly that the local anesthetic is crossing everything, as 50% by some extent a modification of the sensory perception in this area. Once more, it is not an approach of the sciatic nerve, but it is the proof that there is some local anesthetic in this area, and that in this area you have all the genicular nerves. Some of these patients had opacifications, and in all the cases, the dye contrast was going from the sartorius to the bicipital, very close to the sciatic nerve. The local anesthetic went along the femoral artery, becoming here a popliteal artery, was turning around, as I will show you, the adductor magnus, or going very through the small accessory hiatus. We conducted a cadaver study using two different methodologies, and you see that once more, when injecting 20 ml of dye, you have a lot of dye in the popliteal fossa, going in some case very close to the sciatic nerve. You have here the genicular branches, and that there is even some dye within the sciatic in this case. Together with Javis and LaBlanche, we did some cryosections, and once more, you see the sartorius, you see the vessels, you see the sciatic, and you see the ink going from one side to the other side. Another case with the ink going from the sartorius to the biceps, very close to the sciatic nerve. So we were able to show that whatever you inject, the dye contrast is, or the local anesthetic solution is going somewhere, always caudally, in most of the case, turning around the adductor magnus, in some case going around the femoral artery, in some case going in the popliteal fossa through the accessory hiatus. We did some dissections. You see very nicely that the vastus medialis nerve is very far away from the femoral artery here, with the saphenous nerve there. This is another case with the vastus medialis injection performed there. You see that the vastus medialis is not involved at all in this mechanism of action when the adductor block is performed downside. So when a true adductor canal block is performed close to the hiatus, the immediate target is the saphenous nerve, but most of the efficiency is due to a blockage of the obturator nerve and of the superior and inferior genicular nerve close to the sciatic and tibial nerve in the popliteal fossa. Most importantly, these blocks are only analgesic blocks. It means that it is impossible to do a real surgery with this block, and that more than ever, they are only part of a multimodal approach of your technique. Thank you for your attention.